you. Thank you very much, sir, for answering all our questions. Moving on, we have sharing with us her pearls on challenging cataract surgery, the very doyen of ophthalmology, Dr. Lisa Arbisser. Over to you, ma'am.
Good. Can you hear me? And I think you see my screen. Let's see. I need to, on the share screen, I think I need to, just a second. I think I need to enable the sound. Yeah, share sound. I have some of them voiced over. First of all, I just want to reiterate Dr. Arshinoff saying that the Sathis are doing an amazing job of educating us all, and it's a pleasure to be part of it. Thank you so much. We've known each other for quite some time. Okay, share. Hopefully this is all going to be with the sound. Slideshow from beginning. Very good. Does that all look fine to everyone?
Yes, ma'am.
Very good, thank you. So I'm just going to show a potpourri of videos, which I've been asked to discuss just some challenging situations, and in a short time, it can be difficult. I don't think any of my disclosures are relevant. So here you see that there's a patient Valsalva. Once again, I'm asking her to take a deep breath and not to talk and not to nod. But you notice that I stayed present in foot position 0 or 1. And I think it's terribly important that you not only say to the patient, try to warn me if you think you're going to cough, but more importantly, tell them not to lift their head off the table. And then teach your scrub tech to put your hand on the forehead to prevent the head from rising, in which case you can just glue yourself to the patient and never lose control, basically because we're not allowing pressure change in the eye, just as Dr. Arshinoff so beautifully explained.
Ma'am, you need to increase the volume of your audio.
I'm afraid I may not be able to. So I'm explaining, do you want me just to do it? This is the lowest one. So what I'm explaining is that we're trying to do a capsulorhexis on top of this plaque and this very old traumatic cataract, but we're really working hard to try to get it continuous, and it's very difficult to be certain that it is, because really the plaque is essentially has become a part of the capsule. So the important thing is to establish the proper planes. And actually in this case, this becomes a plaque that's part cortex and part capsule. And I think we see this more than we know. And one of the main things is not to disturb the zonules, which are often very fragile as well. So we're going to bring in a scissor here. In addition to using our OVD, we'll do a two-handed technique to try to establish that plane. And of course, we're controlling everything with OVDs. And now we're going to use a forceps similar to the one that Dr. Arshinoff showed us, and be able to take this plaque and actually cut it away. And once that happens and we can remove the plaque, now we're going to have to assess the status of our capsulorhexis and work as though we do not have a complete rhexis, which means we have to be particularly cautious not to lose, not to split out to the periphery. So now we're going to try to loosen this lens. Often the cortical capsular adhesions are significant, so I'm not going to try hard. And instead, I'm going to burrow into the lens with my phaco on, if you'll notice, a burst mode, which allows me to separate the lens pieces without rotation. And now that permits us to have almost no activity going on inside the eye. And only now, when we feel that we've taken out a piece, we could have just moved it forward if it didn't rotate, but it rotated nicely, protecting the very floppy posterior capsule every time we go into ultrasound. And now, never come out before filling with OVD. We're going to try to polish the posterior plaque, which we're pretty successful at that. And rather than risk irrigation and splitting any little problem, I'm going to do manual removal of cortex. There's always more cortex than you actually expect in these very mature cataracts, but they're way off in the periphery. And so it behooves us to actually look when we need to, or go in a very routine fashion, a very consecutive fashion, from subincisional to far away, and then back again subincisional to far away. And then we can succeed in putting a one-piece lens in the bag with this very cautious, somewhat time-consuming approach, but oh so appropriate for a perfect outcome. Now, interestingly, Dr. Arshnoff discussed this. I published with Burkhart Dick in 2013, something we called central dimple down. And you see that this is actually an eye that had a corneal scar. And so the chances of a complete capsulotomy are small. And just as he explained, OVD is the first thing to be put in, and then trypan underneath with removing it with the OVD. And then I was thinking not so much of a Gilzian technique, but the Little technique, which was best published by Brian Little, but really described by Gimbel even earlier, is to bring it to the center. So we just push right down in the center and everything comes in. And that way, if you don't always know where the tags are. So rather than have to inspect along each edge, if you just press right down in the center, dimple down, it will pull it in no matter where the problem, where the tag is. And Dr. Dick has done far more femto than I ever did, and never had a tear out, in his opinion, so he says. Now, iatrogenic, I'm just going to show iatrogenic prolapse here, iris prolapse. And it's because instead of irrigating up into the tunnel, I've irrigated into the eye. And so always your reflex has to be to go to the paracentesis to lower the pressure, because you've increased the pressure. And now I'm properly irrigating up into the tunnel to create my sealed incision. So we don't want to irrigate into the chamber, but especially in the presence of a floppy iris. Never overfill with OVD, because you'll just push the iris out. You don't want to exit on irrigation. I think one of the big mistakes that residencies make is to make residents dependent on continuous irrigation. And it probably saves the coronaries of the attendings, at least early on, because you don't want them to go into zero when they shouldn't. You can always put a detent in the foot pedal instead if you tend to be too light-footed. But if you're in continuous irrigation, there are times when we really want either not to apply pressure inside the eye, like to prevent a retro-lenticular, a retropulsion of the iris, a reverse pupillary block, or for example, coming out with a floppy iris, because that will always let the iris follow. And of course, we have to pay attention to the appropriate size and location of our tunnel. So here, we don't want to worsen zonulopathy by putting our CTR in. And in fact, Howard Fine, so many years ago, said every pseudoexfoliation patient deserves a CTR. Watch how it's going backwards right here. For a moment, it went backwards rather than forwards. And so I've withdrawn it. And rather than even try that, although the next thing to do is fill the bag with more OVD, so it's nice and expanded and it will go around the corner. But an absolute sure way is to put a suture through, or if you're good at the two-handed technique, then you put a Sinski through the leading eyelet. And I prefer not to place CTRs manually, because we're dragging material from the outside of the eye in, but rather to use an inserter. And this way we can not only watch it make progress by using the suture as a tether, we take all pressure off of the equator. And not only that, but in case of a situation that's complex where you might need to remove it, you have a way to easily do so. And when you know you don't need to, you simply cut the suture and pull it out, and you have a perfectly placed CTR every time without worsening zonular pathology, which is the main reason that we know that CTRs don't prevent capsular phimosis and bag lens subluxation, but they certainly make it easier to fix. And there are some that wonder whether we're actually worsening the situation by placing the CTR, but if we do it with this technique or something similar, we won't do that ever. Now, one of the main concerns in, of course, keeping a bag is always the best option whenever you can. And Gore-Tex is used off-label as a choice. I published with Malyugin, Dr. Malyugin, a paper where he showed that proline was actually cut by the poorly refined inside of an eyelid. And so one of our main concerns in all scleral fixation is extrusion, and therefore endophthalmitis, following erosion of a suture. And so what I've shown here is sewing. I first of all will never use any cautery on sclera. I just avoid penetrating vessels, and if necessary, I'll use some topical med or just wait a minute or two by the clock, because I feel that disturbing the sclera, which is so poorly vascularized as it is, leads to melts and problems. And then secondly, you saw that I tied this over the ab-externo hole and then was able to just push it all the way in. I think we're going to see some problems with some of the proline flange belt type things that don't get pushed all the way into scleral tunnels, and hopefully you'll never see a problem in this respect when you cover it properly, of course, with tenons and conjunctiva after no groove and no flap. Hoffman pocket, of course, is another wonderful way to cover these sutures. Over and over, these are cataracts.
You'll have to explain. The recording is not playing.
What's that? You're not hearing it?
Yeah, we're not hearing it. So could you tell us vocally what you're doing?
Okay, I guess I'll silence it. You say you couldn't hear it. I hear it, and I enabled sound, I thought. So let's just talk. Obviously, it's a very brunescent cataract, and I'm using my technique that I call circumferential disassembly, which I published in 2005. The goal is to find that endonuclear space, which that plane is there that we can hydrodelineate in an immature cataract, even in a mature one. And my goal is not to, obviously this is sped up like crazy, but not to go all the way through to the leathery fibers of the posterior plate, but rather to open it kind of like a clamshell. And this is an hour talk, of course, that I'm trying to, and then take out little pieces all at the iris plane or below. And that way we're constantly thinning the nucleophide epinuclear shell, which we can leave in place as a capsule protector and a zonule expander until we get all of the very dense material out. We can always add dispersive OVD, making sure we go into foot position 2 and establish flow before we do anything further. And then you can just flip out that endocapsular piece, lowering your parameters. Can you hear this at all? Say yes or no.
Yes.
The audio is not clear.
We need you to tell us about it.
I'm sorry. What are you saying? I can't quite hear you.
The audio is not clear.
The audio is not clear. That is really a pity. Okay, it's very clear in the video. So the point being that we simply want not to blink And you'll see the spider here, even though I'm protected. See that? Very, very, very subtle. And even though I was protecting the posterior capsule, what I think happened is I got my vacuum, my irrigation just a little bit out into the tunnel at that moment, and that floppy capsule came up. So that's when you don't want to move, you don't want to do anything but put in your OVD and not lose chamber. Now here, I guess you're not hearing any of this sound, so I will tell you this is modified Miyake, and I'm doing an anterior vitrectomy from the two paracenteses, putting the vitrector down through the hole in the capsule. And as you can see, a lot of vitreous came forward as well as calling it back. And when you withdraw, very often there'll be a wisp to the wound. So here I'm making the posterior capsule tear. And as you can see, as we withdraw, which is why we are very careful to use OVD first, as we withdraw, the vitreous will always follow. And you'll see that it followed as we come out. And rather than sweep or whack this wound, which will cause traction, anterior posterior traction, instead, we're going to amputate that by going one port pars plana vitrectomy, still irrigation forward, but the vitrector handpiece through pars plana, and that allows us to amputate the anterior posterior. So David Shane was kind to allow me to use his video of posterior vitreous, posterior levitation for a drop nucleus. And you'll see why I really don't recommend this. And most retina surgeons are horrified at the idea of our putting anything other than a vitrector or a trocar through the pars plana. And so I went to the lab to explore. And what I found, although this isn't perfectly like an intact eye, it's still a wonderful model where the anterior segment is glued to the slide, and you'll see that sometimes you push things posteriorly, sometimes they come forward, sometimes they don't. You can disinsert the vitreous base. So I do have these instruments that I created that you can use through anterior paracenteses to elevate a nuclear particle if it's in the posterior chamber. But if it's in the posterior segment below the posterior capsule, I recommend you leave it be for the retinologist, unless you're in the bush and there is no retinologist available. So although viscolevitation may work well in some people's hands, I think that if we pursue our vitreous, our lost nucleus into the vitreous, we may well end up finding that we really are bitten. So I just wanted to end with that little note that sometimes will make people not forget the idea of some things that are not good to do. I'm so sorry my audio did not work well. I'll have to figure out what I can do about that in future. Thank you so much for the invitation. I wanted to cover as much as I could in 10 minutes, and I hope we have a little time for some discussion.
Thank you so much, ma'am. That was indeed wonderful. Any comments or questions from our panelists?
I think you really covered it so well, Lisa. I think there's not a single challenging situation. You've done a wonderful job. And I think whatever you've done, told us is like pearls, like always. Yeah, and I was just wondering, like Shail had suggested the silicon plaque. Any tips like from your side, which you would like to add on to what he said?
Well, I think for the silicone plaque, I thought that was a superb presentation. I mean, and the only question was, have they ever tried a off-label femto posterior capsulotomy for those? Because that's a very doable thing, particularly when you're not worried about the anterior hyaloid, because you have a vitrectomized eye. Of course, you have to fool the gates into thinking that the posterior capsule is the anterior capsule. And I wondered if you had ever attempted that, because that would be a very clean way to be sure that you got a capsulotomy, and the lens would already be in place, so not really at risk for moving.
That's a good suggestion.
No, I haven't tried it, so I
we haven't we haven't attempted that. The only limitation would be that with these fibrous plaques, even the femto will not cut through them.
You don't think you could make a wider window and a little greater, because you're not any more concerned, about other structures, really, and it's small, well away from the iris. I wonder if you could play with that and make a wider gate and a little higher energy and get that
worth
done.
Considering. Absolutely, it's worth considering.
Thank you so much.
Thank you, everyone. I don't think we have Dr. Namrata